Well, good morning everyone and welcome to this meeting of NHS Devon's Integrated Care Board meeting. My name's Sarah Wollaston, I'm the Chair of NHS Devon. We're meeting in public today and I really want to welcome all of you who are following from outside this room and those who are here today. We're meeting, of course, at a time of unprecedented challenge and pressure, and for that reason we have decided to keep the board as tight as we can, to stick to a constrained agenda. There are several items that were non-urgent that we've decided, due to the extreme operational pressures that we're expecting today because of industrial action, that we'll move them to next month. I'd also just like to note that we do have a further session later on today which is meeting in private, and that's because we're discussing a report related to an individual, and also that there are a few confidential matters about financial forecasting that we will be bringing then when they're ready to be in the public domain at a later session. So there'll be, as I say, a brief private session and then a developmental session for the board, again, kept to the minimum. And I'm afraid as well there are a number of members who would normally be present here today who have to send their apologies, who will be joining us perhaps for short periods during the board, but then having to step away. So we've received apologies for that reason, because of the operational pressures, from Nigel Aitchison, Darren Alcorn, and also from Anthony Fitzgerald. Sheena Asthana also sends her apologies as one of our Integrated Care Board non-executive members. So I think what we'll do is we'll start off with our conflicts of interest register, and can I ask if anybody has anything that they feel they need to amend or related to today's agenda? No, thank you very much. And then we come to the item on the minutes held on the 16th of November. Does anyone have anything that they would like to add to that? No. And then just before we start off on our first item, I'd just like to particularly welcome Kate Shields, who's joining us from Cornwall, and thank you very much, Kate, for taking that trouble. So we're going to come on to the item on our agenda around industrial action, because clearly this is something that's going to be adding to extraordinary pressures that we already face as a system. And thank you very much, Paul, for leading on this item.
That's a pleasure. I think the first thing to say is, obviously, we've had significant time now where health and social care have been under significant and sort of unimaginable pressure, and that clearly continues. It's also, I think, acceptable and more than sort of right to acknowledge, the kind of sort of rights that people have got to express their views and the right to strike. And it's probably fair to say that there's a high strength of feeling within the workforce about the strike action and the issues that they're dealing with on a day-to-day basis. It's also, clearly right to sort of acknowledge the impact on staff who remain within organisations and also our patients. So it's a really tricky time at the moment. Just to look back on the effects of the Royal College of Nursing strike on the 15th, and clearly we had the same sort of action yesterday. It was Christmas sort of day cover that was nationally derogated in the end. We saw about the same amount of service pressure from our population, so demand didn't go down as perhaps we'd hoped it may have done, but that's again for understandable reasons. Trusts all did a whole load of work, and hats off to them in terms of the amount of local derogations that were negotiated, some of which were at the last minute. We didn't get everything we wanted, but we never expected to. So as for example, Plymouth weren't able to get their UTC and MRU departments derogated, as for example, but others did. That's not through any lack of effort. Across the country, we saw in the region of about 10,000 nurses out on strike last week on the 15th, and the South West accounted for about 25% of that. Within Devon, we had a range of percentages of strike action. So 17% within RDU, 12% within DPT, 11% within UHP, and 5% within Torbay and South Devon. And our range reflected the fact there was a range across the country. In terms of impact on care, we cancelled just over 530 inpatient procedures for the day and just over 320 outpatients. So clearly there was an impact on patients. The sense from yesterday, so the second day of the RCN strike, was that the numbers of people taking action were slightly higher, and the view from the front line is that sort of attitudes are hardening. I think it's probably the best way of putting it. So I think we all have to anticipate, which we will be, that this will go into the new year. We're kind of expecting to hear towards the end of this week about being given notice for action into January, and that would, in most likely cases, end up being 24-hour strikes rather than the 12 that we've had so far. But trusts have had, and the ICB have had, well planned and well rehearsed emergency preparedness. And I think it's probably fair to say we've coped as well as could be expected as far as that's concerned. So I think a big thanks should go from the board to everyone that's played their part in that. Obviously, it's the first day of the ambulance strike today. The national delegations ended up agreeing that 75% cover would be given, and that there was a commitment that all Category 1 and Category 2 in public calls were answered in the normal way. From a SWAST perspective, they've managed to find 60 colleagues from the military to help provide cover, and those colleagues arrived on Sunday, I think it was. So there's a 25% gap, so that the military will cover some of that. And when we spoke to them most recently, they were on with discussions with St John's and private providers to try and sort of soak up some of that 25% gap. But I don't think anyone can sit here and say it will be an easy day, even at full staffing. So, for example, toward sort of over the weekend, our Category 2 sort of mean response times were kind of 5 to 6 hours compared to the target of 18. I'm pleased to say this morning we are, from a Devon perspective, kind of in the sort of mid 3-hour range. So actually, it's better than it had been over the weekend. So it may well be that public behaviour is changing ever so slightly in relation to the kind of all the warnings about today. We've got all the usual processes in place in terms of silver command and gold command and multiple calls in the day. So I think we are talking a lot with system colleagues and doing as good a job as we possibly can do. But I think it's pretty clear that harm will occur today and will indeed occur for the next ambulance strike on the 28th. Just looking forward then, like I say, I think it's very likely that this action will go into January. So we'll continue to see significant disruption to our services. The Chartered Institute of Physiotherapists have recently balloted, and in most cases within Devon, they didn't get a mandate. There has been a mandate within Torbay, but that's the only organisation within Devon where there was a positive mandate. And we're still expecting junior doctor ballot to start in the new year. So that was everything I was going to report on.
Thank you very much, Paul. Does anyone have any questions for Paul or comments to add? Jane? So
just to add to that, and again, just to say, I think thank you to everybody who has been really involved in this. So in relation to today as well, we have an industrial action plan, and we'll talk perhaps a bit about it later in terms of the coordination of not just the trust and local authority and our local care partnership endeavours and input, but actually also how we have pulled together the different sort of cells almost that cover the sort of key areas, so in relation to the call to arms. So and that obviously spans both primary care community pharmacy and also our financial cell, because we also have to be able to make some decisions quite rapidly about how we might deploy some of those resources. Also in terms of working obviously with community services, etc. So looking at every possible means to increase capacity. But as Paul says, the industrial action today and next week is very much on a background of quite significant pressures. We've been in critical incidents since Saturday as a result of the Category 2 calls. We have had some significant challenges, particularly in the 111 provider, although we are now more reassured of their capacity and looking to see how we can increase that, because obviously we need the out-of-hospital system to be as strong as possible. But certainly we've also been working through how we use our system at capacity protocol, which we have. And to be fair, that's why Nigel and Darren are not here at this moment in time, although Nigel will join us in time for later board, because they're working on making sure we're clear about what our sort of system triggers are for going in and out of critical incident. And just to also say that Darren, as our EPPR lead, is also working very closely with our local LRFs, keeping them advised of what's going on and ensuring that we've got capacity and ensuring we've got that join up. But certainly a sort of a coordinated effort, and of course sort of wrapping around that, of course, is our sort of communications approach and plan. I'm sure you'll have seen quite a lot of activity in that space. And one last thing, we still, although we are doing really well in terms of flu and COVID vaccinations for people, particularly over 75, we've got some real challenges in our younger population, and that's where we are now starting to see some significant infections. And I don't think we're alone in that, but of course, the strep A has been particularly a hot issue, but actually I think respiratory infections for people, and I'm sure lots of other colleagues are here experiencing that in their own families, but that, that is a significant concern. So we are going to do some further work on promoting and making sure flu vaccination is available, but I think also just to ensure people take that message out and about. Thank you.
Thank you very much, Jane. Hisham.
Yeah. Thank you, Chair. I just want to follow on from what Jane said about the communication, and I think it's really, really important at this time from NHS Devon there is a communication to members of the public about the best advice we can give them in these very challenging circumstances. For example, patients other than Category 1, what they should do given the industrial action, and also things to do with access to care, both in primary care and in acute services. So in terms of quite a detailed communication as much as possible. Thank you.
Thank you. Could Andrew respond to that?
Yeah, thank you, Hisham. As you'd expect, I guess, with a national issue of this scale, there's been a lot of communication done, I guess, directed from ministerial downwards. But actually what we've done is utilise the medical directors by and large, so Mark Hamilton and Adrian, to do a lot of the both reassurance but direct people to the right services. And you may have seen Adrian on television recently. We've also used things, social media, a lot, and also used some paid for advertising to direct people to pharmacies, 111, and we're working with a lot of practices which Joe's leading on about new ways to perhaps text people from their practice about what the best advice is, and obviously push things like flu, etc., etc. So a lot of communications really that's been designed to direct people to use services in the right way and look after themselves. And you may have heard the National Medical Director on this morning on most of the national TV about people minimising risk and looking after themselves at the moment so they don't utilise services.
Thank you very much. I can see Liz from outside the room has a question, and also Graham. So Liz, would you like to go first?
it's less of a question and just an observation, given I'm sitting in a provider organisation that's responding to the strikes at the current period of time. The process that Jane has set out is going to be critical to make sure that we're coordinating all of our capacity across the system if we're going to effectively manage demand and maintain safety. And that includes making sure that we've got coordinated efforts through primary care, our community services and our social care services. And the discipline of the ICC process that Jane set out is going to be critical to make sure that we make best use of all of that and make some risk-based decisions around how we use our total capacity in this context. I also just want to take a moment to commend our staff who have worked, I think, tirelessly over the last few weeks to make sure that we are planning for these events, respecting people's individual rights to strike, but making sure that we do that in a way that protects patient safety and their efforts. You know, just being around the hospital today, I think, is a real tribute to the values of our workforce, and I think we should note that as a board.
Thank you very much for that, Liz. And now we're going to come to Graham and then to Tandy.
Thank you. So I'm conscious that a lot of our workforce are reliant upon their children being at school. And as already noted, this might well be going into next year, and there's potential industrial action in the schools as well. Have we been able to get a handle on what that might do for us, and especially whether that could be unfortunately stacked on top of further action by the ambulance and nurses as well?
Thank you. Paul, would you be able to respond to that?
Yeah, I mean, we're cognizant. Thank you. We're sort of cognizant of the fact that that could well have an effect, and that's part of the planning for next year. Okay.
Thank you. And Tandy?
Just a few comments for me. I think just to note on the communication and messaging re the vaccine, I had a GP appointment not a couple of weeks ago, and as part of it, waiting for something totally different, but I was actually, whilst I was there, asked if I wanted a flu jab. And so I got it because somebody had actually asked me if I got it. So I just wondered if we sort of also, if this is something that's happening across Devon and then taking advantage of patients whilst they're there for something else, just offer them their flu jab anyway. I think that's quite a good way of doing it. I don't know if this is even hospitals, but of getting people to take out that and some stuff. I'm just wondering, is there anything different in terms of how we're dealing with children in this? I mean, I know there's category 1, category 2, category 3, but sometimes for children it's a little bit harder for parents to sort of decide how they're going to deal with this, and I sort of just worry if things like this end up harming a child. I think it gets really contentious. So I don't know if there's anything slightly different, or it's just one message for how people access emergency services, whether they're children or not. That's just my comments.
So just in relation to the flu, an opportunist flu vaccination, others, I think that's pretty standard. I'm looking at my colleagues in the primary care part of the world, looking at Frank, because I think that is, as you say, every opportunity, learning from COVID, actually. In relation to children's, again, Nigel's been working with primary care colleagues. I think looking at different approaches to ensure that we are getting the right information. We do have the Handy app, which I think we've been promoting heavily as well, which has got a particular focus for children, and also I think quite a lot of discussions about the benefits of particular sort of primary care hubs for paediatrics. I think certainly speaking to Nigel yesterday, the best I think evidence is that we really focus on ensuring our primary care colleagues, because they are actually generally the better people to be able to help support children and young people. So that's a bit of a live conversation, but certainly working with our primary care teams through a pretty regular primary care conferences or meetings to ensure that we're getting some of those alignment and those right messages. But certainly I'll take that away and find out the latest from Nigel.
And I just had again on the communications to the public about the strikes. So I've got a routine appointment today, which I haven't received anything to tell me that it's been cancelled or anything like that. So I'll tell you whether it happens or not. It's something else altogether. But I actually also did wonder whether an appointment like mine today could have been sacrificed to free up, I don't know, some capacity in primary care to support what's happening in acute. But just another thought.
Okay. Thank you for that, Tandy. Could I just ask a quick point of clarification, Paul, around the industrial action, about which Category 2 calls won't receive a response today? Because I know there's been some discussion about that. Or will all Category 2 calls receive a response?
The priority are Category 2 calls where the incident's in the public sort of domain, so outside of homes. So that's the priority, and then beyond that, it'll be a question of as and when, you know, the sort of current crews can get to other categories of calls.
Right, so if people are literally outside their home, they'll receive a response, but if they're in their home...
That's the guarantee, yes.
And can you reassure us that they're all going to be triaged as well, so that people, for example, who are experiencing chest pain, are they going to receive a response, or are they going to be triaged first?
That I wouldn't like to confirm in this public board, because I'm not sure, if I'm honest. I don't know if the colleagues are aware of that level of detail, but I'm not.
Liz?
Yes, so I'm going to clarify, because we've had clearly more detailed communications with the provider networks, but our understanding is that Cat 2 calls, as Paul says, external to the home environment will be prioritised, but also other significant clinical incidents, including stroke and cardiac episodes, will be subject to prioritisation as well.
Thank you very much, and obviously we don't want to stray too much into operational detail today, but I'd just like to add my thanks to Liz, Jane and Paul, and everyone who's doing such an extraordinary job today responding to these pressures. We're going to move on now to the Chair's report and the Chief Executive's report. There's nothing that I would like to add to my report other than to just update the board that Jane and I attended a meeting yesterday, and Tracy, with the Minister, Helen Waitley. This was an introductory meeting conducted as part of a review, and we're expecting further meetings with her. It was just to update the board that this was a very constructive meeting, giving us all an opportunity to set the scene and the background to the pressures that we face, acknowledge their extent, and also discuss our plans for dealing with those over the coming year. So I don't know whether anyone has any questions. I can see Tandy's hand up, or is that a legacy hand? No, that's not. Right. Thank you very much. And Jane, did you want to come on to yours?
Well, I just wondered if Tracy wanted to add anything, because I think it was really helpful having Tracy there, and next time, hopefully, Councillor McInnes as our chair of the Integrated Care Partnership. But I don't know your reflections, because of course we have the opportunity. We had the opportunity to provide a sort of the whole system approach. So.
I thought it was a really helpful and, as you say, Sarah, very constructive conversation, and with the Minister, who was actually very interested in understanding the challenges within the system, but also the really good things that are happening within the system. So it was an opportunity to say a little bit about both. So I think it's very much an introductory conversation. They're never quite long enough, are they? But actually, she did offer further conversations when hopefully we can get into a little bit more of the work that we're doing and those key issues for us.
Thank you very much, Tracy. And I'm going to come on now to Jane's report.
And also, the other thing I was going to say, of course, Kate, I think you had your meeting the day before, actually. So just in terms of the context, I think either the Secretary of State or one of the ministers is meeting all of the ICS chief execs and chairs, I think all before Christmas, with that introductory meeting. And the feedback I've had pretty much is, as I say, quite helpful in those first discussions. But again, I don't know, Kate, if you wanted to add anything. As I say, we'll be having some more, I suspect, as we go forward.
So I think our meeting was exactly the same as yours, and our social care Director of Social Services joined us, and Helen Waitley was very interested in our workforce issues, which is something that we'll continue to be talking about. So yeah, it was a good meeting.
Thank you.
Okay, so again, similarly, as always, Chief Exec and Chair of this reports get written, and then quite a lot of things have happened in very fast moving, shall we say. I suppose I just wanted to actually just flag the celebrating staff event that we had on the 12th of December. I know a number of colleagues were able to join us for that, and certainly appreciate that. Very busy time, but actually really important to take the opportunity to recognise and to thank staff, not just within NHS Devon, but some of the partnerships that we work with across Devon as well. So I think, and I want to say thank you to colleagues who were involved in getting that, getting it organised, because I think certainly, really, really important to do that. So that was the main thing I was going to flag.
Thank you very much, Jane. Now, we're coming on, unless anyone has any questions for Jane on her report. Anybody on those? Shall we move on to our section on urgent care and winter improvement? Now, this was going to be Anthony Fitzgerald presenting this, but he has actually been working on today's operational pressures. So Jane Milligan's going to present this part of the report.
Okay, so thank you. So, sort of, I suppose, three things really I wanted to draw out. One is, this is, I suppose, just a relatively brief update on the work that we are doing to develop our integrated improvement plan, which would incorporate not just urgent care but elective care, and to sort of reflect the challenges that we have across the Devon system. Further work to be done on that, because I think it's fair to say we need to really focus on what key actions are we putting in place in the next 3 months, in the next 6 months, 12 months and beyond, and be able to describe that in a way that enables us also to address some of the conditions that we have as a system, being in the System Oversight Framework 4, as well as reflect what's happening in individual organisation and partners. So, and then to some extent also then the resources, both financial but actually also how we are utilising the infrastructure that we have in Devon to address that. So I think it's fair to say we recognise there's quite a lot more work to do on that. In terms of our system oversight position, we're just finalising the governance for that going forward, and working with Alison Williams, who is our Director of Improvement, as part of a board-to-board session that will be taking place, I think, on the 23rd of January, where Sarah, myself and Bill, and in fact Kevin, will be joining other provider chief execs and chairs in presenting our sort of position and our plans to date in terms of the areas that have been identified as part of the operating improvement plan, so particularly obviously urgent care, elective care, our strategic work, finance, and also how our sort of leadership arrangements are working to enable us to deliver that. I think we have got some further work then to do to ensure that we are building up from all of the individual organisations' improvement plans to respond to that, but actually, of course, also what the integrated care system in its widest context. So again, in terms of primary care and our enablers such as workforce, digital, and estates. So that's not reflected in this paper. We've got some further work to continue to build on that. The purpose of the board-to-board on the 23rd will be to reflect back in terms of some of the previous meetings we've had with our regional and national colleagues and progress to date, but actually also to agree what the support offer is likely to look like going forward, and recognising that we actually already have a number of different national support interventions. I don't know if that's the right word, but anyway, support approaches taking place already. So, for example, in terms of the particular pressures on urgent care and ambulance handovers within the UHP and the Plymouth system, as well as having Simon Tapley focusing his time to support the primary care discharge and the flow work. There is also a national team made up of a chief exec, a chief operating officer and a chief nurse from outside of the Devon system as part of that team, and we're aiming to have that coordinated by Alison Williams. And then in relation to elective care, there is also the 10-week improvement plan, which we referenced at the last board, which is also being supported by Michael Wilson. So part of the challenge we have in Devon is sometimes perhaps not always a very coordinated approach. So national colleagues sometimes appear on the patch, and so part of the approach and what we want to try and get agreement on at a board to board is how we ensure we've got a coordinated approach, which is overseen obviously by Alison, but also by Sam Wadham-Sharp and our team, so we have alignment as much as possible. And Sam Wadham-Sharp is working on this in terms of also having clear metrics and measurables of the areas that we need to track as part of our improvement. So it's not without its complexity, and certainly for the next board we'll be able to update in much more detail about those arrangements, and in fact we'll share that probably outside of this board as well, so people are clear about what's being put in place. I can see a hand go. The paper also picks up winter resilience, so I can pause there and then I'll come back to winter resilience if that's helpful.
But does anyone have any questions for Jane, including the arrangements as we prepare for the board to board? Anyone want to come in?
I mean, one thing I just would add, of course, we do have which is why it's really helpful to have Kate here, but the alignment of the work across into Cornwall and across the peninsula, both at the sort of strategic work that we are developing, but actually also ensuring that we've got the flow components right with our Cornwall patients who are also inpatients with UHP. And I know that certainly, as Simon would, I'm sure, testify, and Kate, there's a lot of work happening in terms to ensure that we are maximising all of the capacity that exists, both within Cornwall, but actually also ensuring that the care hotel, as an example, which is in Plymouth, is also made available. And I think there are 10 beds, but that's just a figure really in terms of ensuring that we are trying to work together as much as possible about how we ensure we get people in the right place and actually not in the hospital. That's not without its challenge, and also want to say thank you to Kate, because I know she's been working with her local authority colleagues in working that through, and some of that is about capacity, which is not going to be delivered today, but planning for the for the medium and longer term too. So I think I'm going to leave it there in relation to that, unless there's any questions. Otherwise, I'll go into winter.
I can see that Tandy has her hand up.
Yes, just a comment really, or maybe slightly a question. Just how connected or aligned are we making this work and the stuff and the improvement plan with the acute sustainability program, both in terms of the people who are working on both things, as well as the objectives and the timing? Because I'm sort of thinking that one of it is in the immediate short term, the substance, whilst the other one is a little bit medium and longer term, but I think it is pretty much the same thing in some way. And I think there's some room for cutting out time and being more efficient with how it's delivered.
Yeah, I mean, I think, as I said, the paper doesn't necessarily go into that level of detail, but certainly the next iteration that we're working on will be more clearly aligned to show you that, because as you say, some of the, there's obviously stuff that we need to do today, and is being enacted as we speak, as well as that more longer term plan, and of course looking at some of the areas where we know we've got some fragility and also some workforce challenges is part of that. And I can see Liz's hands come up, so I'm sure she would like to come in on that. But certainly the intention is to be able to much more clearly articulate what we need to do by when, because part of the issue that we perhaps will need to bring back to the board is also in terms of the being in a soft 4 process is not designed to be something that is a long-term approach. But I suppose the consideration will be in terms of what is a reasonable time frame for looking at an exit. And in many respects, there might be some things that we would aim to exit sooner. So elective care, for example, certainly the ambition would be to be out of Tier 1, which is where we've got, which we are doing. So UHP has just recently come out of Tier 1 oversight because for improvement in cancer care or cancer performance. But we also need to look at this in the context of our financial plan as well. So it's almost a Rubik's Cube, shall we say.
Thank you.
Liz, would you like to come in?
Yeah. Thank you. I think it's a really important question, Tandy, because I think the coordination of these programmes of work and the governance and oversight needs to absolutely make sure that we are doing things today that deliver the improvement that we need to do, but have an eye to the longer term plan. This is something as a Peninsula Acute Provider Collaborative that we're very aware of, and ensuring that the governance is fit for purpose. And that's something I know Kate Shields on behalf of Cornwall is also very keen that we get right as well. And the governance and oversight, I think, will help us do that. The other thing we need to make sure is that the people that are engaging with the system as part of software in support of some of the programmes, and Jane's mention of a couple of them, so Professor Tim Briggs, for example, and Michael Wilson, who are welcome support to the system to help us design and identify opportunities for progress, but making sure that we're tying that work into the oversight and governance arrangements is going to be critically important, and it is a priority for the Peninsula Acute Provider Collaborative.
Thank you.
Thank you. And I think, Jane, you want to add anything on winter improvement?
Well, just two things before I go off. I think also we just need to also be clearer. It's interesting when you have to sit down and prepare for a minister meeting, you have the opportunity, well, I did have the opportunity, to, I suppose, really review everything that's happening. So I think in terms of being able to look at our challenges, actually we can describe then what we are doing about it, and also what's coming now, but actually what's coming in the future. So we have, for example, a number of capital development schemes, coming online early into next year in relation to extra capacity for theatres in UHP. Obviously, the AMU, the medical assessment unit for Torbay has opened. So I think we also just need to be able to describe as part of this some of those other schemes, because I sometimes think we just don't always see the full picture. So that was that. And then in terms of winter resilience, again, we have, as I say, we did actually establish an approach to a tactical control process probably about this time last year, or certainly earlier this year. But certainly we have done a lot more to solidify that almost, and put that more put it in a bit more of an operating framework. And and to some extent that is still developing as we respond to the current challenges, and certainly in terms of working through our system capacity protocol and the triggers that we need to use in relation to not just as an organisational level of OPAL scoring, but actually as a system as well. So that's certainly work that we continue. We do have as I say, a physical tactical control centre, which is in County Hall, but although of course to some extent, because we cover more than one provider and a large patch, we also have a virtual approach to that as well. But we are we have a capacity. We have appointed to a number of posts to support that. Some of those will not yet come online until the new year, but just to reassure colleagues, that's what we have in place. I think, as Liz has said, ensuring that we've then got the right approach and the levers to pull in terms of how we can get the best out of all of our capacity is really important. And in fact, tomorrow, with everything else, but actually I think will be really helpful, Julian Redhead who is the National Lead for Urgent Care, is that right, Kate? I think it's got and a clinician by trade, is coming down to visit, I think, certainly Devon and Cornwall. Yeah. And I think Bristol as well, because we've got both some of the biggest challenges, but actually also the biggest geographies too. So we'll hope we'll be able to work with him and get his hopeful input into the approach that we have established, but actually also if there are any particular gaps that we have. I think it's fair to say we've still got some work to ensure that ensuring that we are applying and adhering to some of the standard operating procedures that we have in place. And actually the other thing to add is that with our local authority colleagues, we also have an OPAL system of escalation, and you will also know that we've done the same with working with our general practices and the local medical council. We have something similar as well. So we have aimed to really ensure we've got a temperature check across the whole system. Obviously, sometimes getting access to the information for all of that is not without its challenge. And of course, we often do look at the ambulance handovers as one indicator, but as I say, we're trying to identify other indicators which are a particular reflection on system pressures. So more work to be done in that, but certainly that is in play.
Thank you, Jane. Kate, you'd like to come in?
So I suppose what I wanted to say in some respects is that this challenge has come a bit too early for ICBs, because what we're being asked to do is what we've been set up to do, but the pressures are all live and they're everywhere. So if we could look back in a year's time and see the steps that we've taken now, we will see the linking of services at place in communities with hospitals, both for diagnostics and for treatment and for discharge. And we're having to make all of that work together very quickly, and not all the data is available in the right place in a format that we can use. So primary care, for example, it's really hard for us to see appointments on the day, but we need them because we need primary care to step forward and to do some of that at-place management for us. So the SCCs, we've got an SCC, System Control Centre, and we have used controlling language, because it has to be a place where everything comes in and we can hold ourselves to account for moving in concert. So I think when Julian Redhead comes to see us, he'll see us as a work in progress. So we're really looking forward to the feedback that he gives us so we can tighten it up and move on.
Thank you, Kate. Yes, Sarah Lou.
Yeah, I'm just wondering, are we able to get the information that we need from voluntary sector organisations as well in the community where they're supporting?
So I think we do get that actually at a locality level, so that to some extent is one of the bits of information we do have. We don't necessarily, and the whole point is that to some extent, as Kate says, we've got to have sort of some form of control and oversight, but we don't want to undermine what is actually happening at each of the local care partnerships. And the local care partnerships, and again, recognise different levels of development, are where a lot of those local relationships and that work happens. So what I'm really keen that we don't do is try to suck something up to some mothership or fathership or whatever in a way that undermines that local work. So, I mean, it's... but if there are areas where we need to... So the 11 o'clock call, which happens on a daily basis, is where we get the feed-in from all the localities and local authority. And so it's the system input. And if there are things that are being escalated there, or even good ideas, that's where we are utilising that. And then if there are things that then need to be considered as a system, then that's where we have a gold call. We don't have anybody from a local authority perspective on that, but I think there's enough knowledge in between local authority DASs and chief execs, as well as so Anthony obviously is the chief delivery officer, but also line manages the local care part, the directors of the localities. That's where we bring that together.
Thank you. Could I just ask a question as well, please, Jane, around, there's a huge amount of different work streams going on, as we heard yesterday, and is there an inbuilt process of evaluation so that we can also assess what isn't working so well, and so that we can be clear about what, looking at over the horizon, what we need to do more of and what we need to do less of?
So I again think that's a bit of work in progress, although I do think through value for money approach, and Bill and I have been talking about that, because I think we do need to put in place, and I think certainly through the work that Sam Wadham-Sharp's leading in terms of the metrics will enable us to be more clear about that. But I think it's probably not clearly articulated, so I think I'll take that away as an action. But it's a good question, because I think certainly we recognise, and particularly in the heat of the moment, needing to put in place some things. There's a requirement to do that quite quickly, but we are trying to ensure, and in fact we do have to do quite a multiple of returns to region about how we are utilising our resources. So that in itself does build in some of that evaluation, but I think we need to do some more sort of forensic review of that.
Thank you. Any other questions from colleagues? Well, thank you very much, Jane. We're going to come on now to our Quality and Performance Committee update, and Hisham, thank you very much.
Thank you very much, Chair. So there is a written report which I trust colleagues will have had an opportunity to read, but I'll just focus on some of the highlights that would be interested to members of the board. The last meeting we had, which I believe was the 7th of December, was one of the first deep dives we've had as a committee, and it was focused on children and young people's access to speech and language therapy, communication, and autism services. And the focus of that was really about access, and as a committee we were not particularly assured about that, because there remains quite a long wait for the population in Devon, particularly children and young people, to access those services. Though both of these have been through service improvement process, and we had quite a lot of debate about in the committee, and particularly afterwards, on the approach to deep dives. What sort of questions we should be asking our colleagues that present in committees about deep dives, and what is the ask from a system point of view. But actually it also raised another question, which is the role of NED-led assurance committees, and should we just depend on data that's presented in the IQPR? Because as far as the Quality and Performance Committee is concerned, the deep dives are data and risk-driven. However, there is an element of assurance that we can't get from just provider presentations and IQPR data, and that is NED-led assurance visits, which happen ad hoc but are not structural or in a systematic approach. I know that the exec team have some of those visits. So these are some of the discussions we're going to have, and I'll give an update to the board afterwards. The second element of the discussion was about the IQPR data, and again, as colleagues will have had a look at them, when it comes to urgent and emergency care, there hasn't been really a significant improvement in the metrics, though there are definite pockets of improvement, though they've not reached significance because we're waiting for more data. So again, the question to all of us is, when do we as a board or as individual assurance committees decide that a series or a set of actions have not been effective? That links to your question, Sarah, just earlier on. And when do we then say we need to look into alternative or contingency action plans? So that's something that I think we should be looking at. There is a confidential part of the report about patient A, and that's not in the public domain, but there are a set of recommendations following the investigations there, and I believe that will be discussed in the private part of the board. So I'll stop here and very happy to take any questions. Thank you.
Thank you, Hisham. Does anyone have any points they would like to add to Hisham's report? Thank you very much, Hisham. And we're going to come now on to the Integrated Quality Performance and Finance Report, which would normally be led by Darren Alcorn, our Chief Nursing Officer, but as Sam mentioned earlier, he is tied up with operational pressures. So again, thank you, Jane, for leading on this.
Okay, so I'm going to be brief. I mean, the report's in the pack. It's certainly, I know a number of non-exec colleagues have seen it both in the quality committee as well as finance. I think it's fair to say, again, we are aiming to continue to refine and answer the so what question. I think as has just been referenced to, and to some extent also with any report, of course, they get out of date as soon as you write them. So I'm just looking at the COVID numbers because, of course, that's definitely changed since November. So I think the intention was to, though, I suppose, present the total picture, but I do think as we move forward as a board and in terms of our governance review, as well as the work we need to do to shape how we bring the right information to this board, we've got to then look back to how we our integrated performance report is then reflected there. So I think it's fair to say it's got a lot of information, and but I think we've still got some work to do in terms of then articulating the so what. So all help, because I know non-exec colleagues have been really helpful in helping us shape this, but more work to be done, I'm afraid, everybody.
Thank you, Jane. And Judy has a question.
I think this has progressed massively, so thank you very much. You're absolutely right, Jane, more work to be done. For example, there's work going on at the moment to try and see how we can measure primary care and feed it into this. One of the things that happened when we had a presentation at the Quality and Performance Committee was the young manager who came to present this to us actually drew conclusions from, I don't know which pages, but if you look at page 20 against page 5, don't look at those because I'm just making them up. But what she was doing was drawing conclusions that asked questions, and it was incredibly valuable. And I'm absolutely sure that the staff who are working this all the time actually do see that bigger picture. And I think it would be lovely, as well as all the analysis we have under each chart, which is incredibly helpful. I mean, I have, this is just streets ahead of what we used to get. So, but I just think that, that overview that the staff are working on all the time would be worth a page at the front. And even in the board summary paper, if you look at the whole system, you will wonder why X is happening, but Y isn't, and yet you would think X and Y would happen together. That kind of skill that they clearly have that we're not getting in the way it's reported to us at the moment.
Jane.
Yeah, no, I think, and that's certainly what we're looking to look at. I mean, I think, as you say, it's that triangulation and analysis. Again, I don't think we're alone in trying to be able to do that. And then also, to some extent, well, what are then the levers, or where does the accountability or the action sit? Does it sit at individual provider, or does it sit at one of the collaboratives or the local care partnerships? So, and I think that's key. I think also what is helpful, and as you say, what we are trying to get to a place where that triangulation does give us a better understanding of where to put in place some of those actions. So if I just, again, one of the things that was commented on yesterday at the ministerial visit was actually our performance as in Devon as an ICS across in relative terms to South West for discharge is actually the best. Now, I'm not suggesting it's perfect, and our no criteria to reside target is 5% of the bed base, which is a very challenging target. But at the moment, we are often within 12 to 15% of that, which is compared to the variation across the rest of, not just of the South West, which is, I think, averages of 20%, as well as across the country. We are doing something right. It's not, as I say, it's not perfect, but we are doing something really right, which was really nice to hear yesterday. And I suppose then that goes back to where do we then put the effort? So if, in fact, the Minister was drawing conclusions to some extent of herself, saying, well, you're doing really well in discharge, so why are you still having all these challenges with A&E? So then that goes back to how we are making sure we have got the input or the intervention. The intervention's not quite the right word, but the improvement, that's the word I'm looking for, in the right place. And some of that will be still about what happens outside of the hospital, but also happens inside hospitals, as well as what happens in the wider system. So that's where we're trying to strive for. But hopefully, Judy, for the next report, we are working on exactly the actions you have identified.
Thank you. Do any other colleagues have any questions on the report? No. Thank you very much. So we're going to come on now to the Finance Committee report update, and that's Kevin, and this is to review and discuss as well.
Thank you. So I'll take the report as read. The key item, I guess, is the financial position of the ICB, which Bill is going to cover in the next item. But just building on the conversation we've just had around the IQPR, there is, of course, quite a bit of further work to do to align the financial reports to the IQPR, and that work's ongoing at the moment, and we're hoping that by January, February time we will have aligned those two reports and pulled out the triangulation as we've just been talking about. But I think that's the only thing that I would want to flag up. Happy to answer any questions that anybody has.
Thank you very much, Kevin. And so that brings us on to Bill Shields and the finance reports. Thank you.
Thank you, Chair. I'll take, with the Board's permission, the two reports, the ICS report and the ICB report together. These represent the financial position of NHS Devon as at month 7. And at that position, that showed that the organisation and the organisations for whom we provide system oversight continued to project a deficit plan of £18.2 million, which is in line with the plan that we submitted to NHS England. That is predicated on efficiency savings of just under £139 million. And I think what is becoming clear, and what will be discussed later in this meeting, is the ability of both the ICB and the organisations within Devon to deliver that savings plan is now something which is a cause for concern. So the risks that are emerging through the course of this year, which have been discussed in detail at the Finance Committee and also flagged at this board when we last met, are now of such a size and scale that our ability to meet that target has to be called into question. Work has been ongoing, both within this organisation to stabilise the ICB financial position and forecast outturn, and also with each of the organisations within NHS Devon to be absolutely clear about what the financial positions of those organisations are, what actions have been taken, and what mitigations can and have been put in place. It is likely that we will, at a future point in time, look at those positions again and as a consequence determine our ability to be able to continue to forecast the £18.2 million deficit. So I think it's really important that the board understands that our ability as an organisation and the ability of those organisations for whom we provide system oversight to deliver against those plans that were submitted for this fiscal year has got to be called into question. If that's the case, then there is a detailed process which the board will be apprised of that we need to go through to change our in-year forecast position, and that will require us to go through a very detailed protocol, as will each of the organisations that changes its position, and that will then need to be signed off by the regional team of NHS England. And at this point in time, we're starting to look at that process and to understand how that process will be adhered to and what the requirements for this organisation and each of the organisations within NHS Devon will be. Needless to say, and I don't think it will come as a great surprise to anyone, that will mean that there will be a significant tightening of the controls that are currently in place in terms of the double and triple lock process. That will mean that our ability to undertake discretionary expenditure, and also each of the organisations within NHS Devon to undertake discretionary expenditure, will be severely limited. And that will also mean that the reporting arrangements and the scrutiny that we are subjected to will increase quite significantly as a consequence of those changes. If we are in a position where there is a change to the forecast, I think what's really important, and work is now commencing on this, is to ensure that the recovery of the current financial position is something that's achieved as swiftly as possible, and that all of our efforts are redoubled to ensure that the position does not deteriorate further into the next fiscal year. Those are the issues that we are working on. I'm happy to provide any further detail to the board. As has already been indicated, there'll be a more detailed discussion about the month 8 position in Part B, but in terms of the month 7 position, I'm happy to answer any questions or provide any further information.
Thank you very much, Bill. Does anybody have any questions at this point? No. Thank you. I think, as you say, we can have a more detailed discussion at our later session, so thank you for that. What we're going to do now is take a break, and we're going to reconvene here at 11:20, please. Thank you.
better doing so next time.
Well, welcome back, everybody. And we're coming to the next part, which is on strategy. And Simon is going to lead the discussion on the integrated care strategy and where we are with that. So thank you very much. And this section is going to be for noting. Thank you, Simon.
Okay. Thanks, Sarah. I wasn't intending to spend a lot of time on this. I know you and James have been heavily involved in almost a page turner, I think, at Pomona a week or so ago. So it's been issued to stakeholders today. We can continue to iterate this strategy. So I'm happy to take any questions. The next stage for this is how we work up our response, so the joint forward plan. Alison Wilkinson is working on the detail of how we'll do that. I'm more than happy to bring back something to board in January, setting that out. We're obviously not starting from scratch. You alluded to the work that Liz is leading on the Peninsula Acute Sustainability Plan as one of our 4 main pieces of work that will respond to the strategy. So happy to take any questions. As you said, Sarah, it's just for noting.
Thank you very much, Simon, for all the work that you're leading on this as well. I'm very keen to make sure that James McInnes has an opportunity to comment on this as chair of the One Devon Partnership.
Thank you very much, Sarah. And could I add your thanks to everybody? I think in the time span in which we've had, I mean, traditionally used to be, you take a year to put a strategy together, and it has various unfoldings and looks at again, and we've had to do this in a very short time. And I'd like to thank particularly Simon and the team in the NHS, but also public health colleagues across the 3 authorities, and where they've actually worked together and with the local GESNAs bringing together, the key about 80% that was actually general across Devon, and then working on making it more individual. As Simon previously said, you and I had a session only, was it last week or was it the week before? There's so much going on, like keeping up with the weeks, where we went through the challenges and the goals and tried to make them a little easier to read, and also try and make them not too general, very much for the people of Devon, because it's the geographical Devon, because I think it's very important that our strategy challenges and goals actually relate to people. Because I think we do sometimes get so within ourselves that we sort of think it's about process. It is about process, but it's also about this is about the people of Devon, the geographical Devon, and us being able to work as a system as best we can. We have just because I know you want to move on, Sarah. Just lastly, you will notice we haven't got highways in here or transport or anything like that. And that was in an early iteration, but we felt very strongly that we need to keep to issues in which we have the ability to influence and change. And if we get down that road, it's a very broad thing that would actually be very difficult in the current financial situation, particularly, to actually make the changes that some people would like. So I'm very pleased with the document. It's a long document. But it is a read that actually explains where we're going, and I think for me it's anyone who comes to it cold will actually hopefully understand One Devon when we finally come to the goals and the challenges that we face. Thank you, Sarah.
Thank you very much, James. And I'd just like to stress that it is a work in progress. This is a draft, and so we're very much looking forward to hearing more detailed feedback so that we can get it in a place that we need to be. But we did have a requirement to have our first draft out by the end of December. I know that Jane wants to come in, but also I can see Liz. So Liz, shall we come to you first, and also then to Tracy and Jane to wrap up? Thank you. Liz.
Thank you. I'll be brief, and I will echo what I've heard. I think it's a really well-constructed document, and I think the narrative really brings some of the aspiration alive, which I really welcome. I think the real test is the so what test then, and what it is we do. And I think when you look at the section around conditions for success, one of the things I think we can pull out of the narrative that is there is around how we take a more personalised approach to the needs of our population. I would really like to see that as we move into the more detailed plan. But other than that, thank you. It's very helpful.
Thank you. I'll come next to Tracy.
Thank you. And just to support what Liz has said, I think it's a really well constructed document, and it is a good read, Simon. It is a good read.
You sound very surprised.
Well, it was just he said it was a riveting read, and I thought he was being a bit sarcastic there, but I think it is. And I'm also really pleased that we've just slightly narrowed the focus. There's plenty to be going at here, and there's a lot to do. So I would just support what James has said about let's focus on this part of the system, and actually through the work that perhaps James and I do, others do across the wider system. Actually, it's holding others to account for making sure that other parts of the system are doing what we need them to do, in the same way that other parts of the system will say, hang on a second, health and care integrated system, what are you doing for us? So it very much is systems working, and we can see those key elements in here. The final part, which I always say, is as we get into the next iteration, understanding what the picture on the front of the jigsaw looks like is always really helpful in terms of when we get into what do those delivery plans look like, just so we can always make the connections back to where we are in the big picture.
Thank you, and I think it's fair to say we had a lot of discussion around targets and how detailed we should be about those, and how far those aspirations should stretch. Judy, I know, wanted a question. Is that all right, James? And then I'll ask you to have the final word, Judy.
I wanted to say that I thought it was one of the not easiest to read, best to read strategic plans I've seen in my career. It just is so much easier to read than so many, so thank you. I just wondered what our system was for monitoring this over the, not our NHS Devon, but the whole system's plans for monitoring the implementation of it.
Shall I have a stab at that, answering that question? I think that the One Devon partnership will play a key role in that, in actually holding all parts of the system to account for where we're not making the progress, and also for looking at where we're not working in an integrated fashion. But I think the whole point of this document is to be a blueprint for which all other strategies across our system have to be coherent with it. So I think it is a case of saying, well, this is what we want to collectively deliver, and all parts of the system have a responsibility for doing their part in delivering it. Jane.
So yes, and thank you to colleagues and for the feedback. I think the ambition really is to get to a place where we have a plan on a page, and then to some extent, as you've said before, with identifying what are the, how are we driving metrics. And I know we had a crack at that in the days of STPs in terms of some of the outcomes, but it was often difficult to utilise those in a way that were meaningful. So some of the educational outcomes, the timing of those being refreshed made it quite difficult to use. So we have to work with our colleagues, I'm looking at Steve here and others, about how we can sort of hone that down, because I think the more we can do that, the better. I suppose I just want to say, to some extent, we were sort of expecting a bit of guidance nationally as part of the joint forward view. That appears to have gone, which is probably quite welcome, isn't it, in many respects. But I suspect something will pop out of the operating planning, which we'll need to just double check back against the intentions. I was very irritating at the walkthrough, because again, what for me is, so what makes us different in Devon, really different, and what are we going to do differently? And I think certainly more of the same, I think we recognise is not going to cut it. So again, looking to colleagues' input into that, and I think also, as you say, further work we need to do about how we get collective sort of system, everybody within the system owning this. So I think there's some sort of development work we'll need to do going forward, and with Councillor McInnes's really fantastic support in that space. we also need to look at outside of Devon, you know, so I know the opportunity I think we're hoping to have with Kate and Cornwall colleagues to sort of do a bit of compare and contrast, and, you know, pinch with pride is always my motto, and of course to some extent in Somerset, and particularly because we share the same academic health sciences network, and I think certainly we should be asking them also for their response to our draft strategy. I know they've been really involved in it, but I think they play a really important role in terms of some of the things we've talked about in terms of evaluation, but actually also some of the innovation pieces. So again, more work to do on this, and the key thing also is we need to make sure it is actually sings to people. It's still probably a little bit health dominated, and that's always the case when you've got we always have to keep challenging ourselves in that. But certainly we then, of course, this will then be how we collectively as an ICP and as a board would then go back and review our priorities to make sure there's a match. So there should be a golden thread, she says, to use a well-used phrase. But, you know, we mustn't, because I think, again, perhaps part of the challenge we get is that we have too many strategies or too many plans. So what is the single, you know, source of truth? And for me, that will also be part of our discussion with the board to board and nationally. Again, that's obviously the finance component, but we also then, as we go forward, working as an ICS and ICB.
Thank you very much, Jane. So there's no other comments on that. We've noted that, and we'll come on to the memorandum of understanding between NHS Devon and NHS England. And this is something where we do need the board's approval. And Nigel, thank you for coming back to present this item.
Chair, thank you very much, and can I apologise to you and members of the board for my non-full attendance at the meeting, and thank you for allowing me the time to manage what is quite a tricky set of situations across the system, so thank you for that. As the Chair said, this is an item that we would like approval of the board from following presentation and discussion of the item to allow it to be taken forward to be signed by ourselves in NHS England. I think it's important to start with what it doesn't do. It doesn't change the statutory roles and responsibilities of either NHS Devon Integrated Care Board or NHS England, and neither does it change the accountabilities of individual NHS organisations. But what it does do, it describes principles that underpin how NHS Devon and NHS England will work together to discharge our collective duties to ensure that people in Devon have access to high-quality, equitable health and care services. It sets out the delivery and governance arrangements across the Integrated Care Board and partner organisations. It sets out how NHS Devon, NHS England and NHS Foundation Trust will work together and implement the requirements of the NHS oversight framework, taking into consideration local delivery and governance arrangements, risks and support needs. And finally, it sets out how NHS Devon and NHS England will work together to address development-specific needs in both the ICS and in the region. And you'll see from the content that it sets out a number of different things. It sets out the ways of working, sets out system priorities and deliverables at a national system and place level, locality priorities, and partnership and place arrangements around our 5 local care partnerships. It covers health inequalities, our responsibilities under net zero, our operating model, our governance and oversight, and roles and responsibilities in performance improvement. It also covers ICS development. So the detail colleagues will have had a chance to read in the papers, but that's in summary what the paper covers, Chair.
Thank you very much. Can I take any questions on the MOU or any comments? In that case, can I take it that the board is approving? Thank you. Right, that brings us on to the governance and risk section, and first one, Tandy is going to lead out on the People and Culture Committee update. Thank you, Tandy.
Thanks, Sarah. I'm not going to take too much of your time. Much of what's in this report you've probably heard from the other reports that have come across, or you see in more detail in the other reports. So at the last meeting, we discussed all issues to do with workforce development and the challenges, including the very well-known issue that we will not hit our target for £28 million in energy, in agency spend, and I think that's part of the overall financial picture that's not looking very great. But there are plans underway to make sure that in the end we sort of increase or sort of make more use of in-house agencies, and that's work in the background. Workforce strategy is ongoing, and hopefully that should be finished in 2023 and 2024. We also sort of heard from Tracy, who spoke to us about the integrated system development program, and I think much of that work has also been reported already, so I'm not going to spend too much time on discussing that. But in the end, we did agree that we need to start looking at 3 areas, which is have a deep dive on the international recruitment hub. On recruitment for international staff, we've recruited up to 600 nurses so far, and we think that the satisfaction levels in terms of how those nurses are sort of settling in has been very high. But we then sort of now need to start looking at retention and making sure that we're keeping them and we're not just recruiting from outside, they're coming in here and then moving on. So the committee also agreed to have a deep dive on retention, as well as a deep dive on the international recruitment hub. But of course, we're also expecting the workforce strategy to be brought to the meeting in February.
Thank you, Tandy. Does anyone have any questions for Tandy? Hisham, thank you.
Thank you, Chair, and thank you, Tandy. Just a very brief question regarding workforce training. I note that that's not part of the deep dive. Is there any forecast about looking into that in the future, in addition to retention and recruitment?
Paul, do you want to add a bit on to that?
Yeah, I mean,
I mean, there is basics.
Yeah, I mean,
Yes, sorry,
yeah. At the previous meeting, we had quite a comprehensive presentation about effectively a learning academy for Devon, and we did agree that I think every quarter we'd have a deep dive on the activities of that particular part of the organisation. So, in short, the answer is yes.
Thank you. And any other colleagues want to come in? No. Well, thank you very much, Tandy, and I know that you have to leave, and thank you very much for coming and presenting at this part. Thank you.
Thank you.
Right, so that then brings us on to the Audit and Risk Committee, and again, this is a discussion. Thank you, Graham.
Thank you very much. There are 4 things I'd like to raise at this point, please. The first relates to the external audit. As already reported, we did not have an auditor in place for the last 3 months of the CCG, and our prior auditors, Grant Thornton, had declined on the basis of conflicts of interest to continue to working with us. That led to a procurement exercise to seek to secure one of the big firms, which was unsuccessful, which therefore leaves us without an auditor in place. And as previously reported, we have raised that, and Bill has raised it in particular through region, heading towards NAO, and that is in progress, and clearly would be very keen to make sure that as we approach year end, which isn't that far away, it would be normal practice to have an auditor in place, because obviously the balance sheet date is a particular date in time. So I will report back on that in due course. The second thing is around single action waivers. This is the process by which Bill, as CFO, can exercise powers to elect to place contracts without going through procurement tendering process. We observed that it is currently split in terms of where things go to between finance and audit and risk. We're aware that there was a governance review on only one of the 2 committees, not currently straddling 2, and normal practice would be that that does indeed sit in audit and risk. The logic about that is that this is already a decision that's been taken. And therefore, the key things to do is to provide an opportunity to scrutinise whether, in fact, that power is being appropriately used or not, and whether there is a pattern of the overuse of that, or indeed underuse of that, and that would typically fall in the remit of an Audit and Risk Committee. So the proposal is that in the governance review, that firmly sits in one place only, and I think, Kevin, you've agreed to that as Chair of Finance. The third thing I wanted to raise is the board assurance framework. Again, you will be aware that work has been ongoing and hasn't yet reached public board, but in due course will do. But we did have the opportunity of putting in an organisation and organisations and our providers who are very, very busy, that we are indeed putting in a proportionate amount of effort. And that then took us to the last point I'd just like to raise, which was that having identified mitigations and having bought into it, we then have to deliver those. And actually, all of those things do not sit wholly within an organisation called NHS Devon. They sit within providers as well. And so we discussed how we were going to take this forward. And in the last meeting that I held with the audit chairs of the big providers in Devon, we agreed that we would run a workshop. So this is the fourth point I want to just raise, is that we are proposing a workshop that ties in, as opposed to be separate from the risk management process of the ICB as an organisation, because clearly we cannot identify and agree how to mitigate plans and monitor them without collaboration across the entire system. And so it begs the question of how exactly that's going to work. So we will be scheduling a workshop, a true workshop, with the chairs of audit and risk across the system. And if Cornwall wants to join, I'm sure that would be more than acceptable. As a way of welding together how risk is going to work across the system. So that was the fourth thing that I wanted to just brief the board on. Thank you.
Thank you, Graham. And would you like us to put that as an action, so it's there on the action log and you can update us when that's taken place? And we look forward to having further discussions this afternoon at our development session. Thank you. Does anyone have any questions or comments for Graham? Yes, Sarah Lou.
Graham, I just wanted to say thank you for the last comment about the workshop. One of the things that I'm coming across in many discussions with organisations is that if there isn't enough distribution of funds in one area, then can we ensure that if local authority are making certain cuts in certain areas, or we're not achieving what we're able to do at the moment, and how that is working across system in NHS as well. So I think that's extremely welcome from my point of view.
And just to say that one of the things that is a very loud message from the audit chairs in the system is indeed the close working relationship that we have and need to build on with the local authority. I think everybody's really cognizant of that relationship.
Thank you. Any other questions from anybody? No. Well, thank you, Graham. Right. So now going to come on to Judy Hargaden and the Primary Care Transition Committee update. Thank you.
Thank you very much. There was one issue that I was asked by the committee to escalate this group. Sorry, still trying to look at how to use this digital bag. Which was the cost of locums in primary care, and that is of the same kind of concern, I think, as some of the agency and locum costs for some of the specialist staff in acute services. We have a particular situation which may be adding to the problem, and there is a lot of work going on this, but in order to manage a situation in one part of Devon where services had massively deteriorated, we have a temporary contract with a provider who stepped in to help us, where we are supporting the costs of them settling the service down. They are making really good progress, but that is a support that we don't give to every single practice. And some of our practices are really struggling if they're in competition to get locums and agency staff. So that explains why it's slightly more complex than just the cost. The other things I would just highlight is we are getting ourselves ready for the delegation of dentistry, pharmacy and optical services, and each meeting we're taking a detailed briefing session on those. And just going back to the first point, one of the things we're working quite hard on at the moment is to prevent these cycles of deterioration. You know, vicious circles start when one place has trouble and we don't get in and help early enough. So there's quite a bit of detailed work on how can you work more supportively with practices who are independent businesses. And so that's a nuanced discussion that we have at most of our meetings. Happy to take any questions.
Thank you, Judy. Does anyone have any questions for Judy? No. Thank you very much. We come now to the remuneration and strategic workforce update from Kevin Orford. Thank you.
Thank you. So this was an extraordinary meeting with one agenda item, which was to approve the very senior manager annual pay increases, which the committee approved in accordance with the Minister's recommendations and the associated guidance. So that was the main item for the agenda. And I have nothing more to add to that. If anyone has any questions, happy to answer them.
Any questions? No? Well, thank you very much, Kevin. So we're going to come now to the action log, and there's just one item on the action log that is in the agenda that isn't quite correct, and that is the action log item number 3, where we were going to share the report from Dr. Hooper on long waits during COVID. And it says on here that it's been shared, but in fact it hasn't been shared, and I'll just confirm that with Jodie, who's emailed the individual responsible. So we're not going to request to close that. We're going to keep that in progress, and rather than request to close. Does anybody have any comments on the other ones, or shall I take it as read that we're going to close item 19 and 25? And I don't know whether, Jodie, you want to update us on the others? Sorry.
Sarah, it's just on the action for Better Care Fund. I thought there was an action that we were going to go back and look at how the decisions had been made, and I'm not sure where that's getting picked up. Because it sort of played out this winter that perhaps some of those decisions had not been made as well as they could have been.
I think it's on the forward planner. Jodie, okay. Could you confirm? So we closed it simply because we'd added it to the forward planner, but it's so we have the forward planner that we can refer to, but rather than have them all as open actions, once they're on the forward planner, we're going to take it that they will be dealt with, but that is definitely there. Jodie's confirming. Thank you. Are there any other items that people would like me to add to the action log, other than the one we've just discussed from today's meeting? No, lovely. Right, well, in that case, can I just check whether we have any questions from members of the public? No questions. And then in coming to any other business, does anyone have any items they would like to raise there? No? So just to confirm that our next meeting is at Derriford, we agreed that we would try and rotate round the locations of our board meetings. So we are going to be at Derriford on the 18th of January. And so I think now this brings us to an end of our public meeting. So just in closing, again, I'd just like to thank everybody for their contributions today, and to all of our incredibly hardworking staff across the whole system, and to wish everybody season's greetings and say thank you, especially to those who'll be working over the holiday period. So thank you very much.